Falls are not new issues among hospitalized patients, especially geriatric patients. Do you wonder what are the factors affecting falls? So that's why my team and I explore this issue. Hi, I'm Noraida from Department of Dietetics, Faculty of Medicine and Health Sciences, University Putra, Malaysia. Okay, prevalence of falls occur 1/6 older patient. They will experience at least one falls each year. So this one actually leading to the second cause of the intentional injuries death worldwide. So about 80% of the low and middle country experience falls, and then about then the greatest number of falls occurred among older patient aged 60 years and over. So why falls common among older adults because of the aging issues caused by the action of variety of the molecular and cellular damage, leading to physical, sensory, and cognitive changes, and also balance problem and muscle weakness that actually make them higher risk of falls. So the potential consequences of fall include severe injuries, increased morbidity, prolonged hospital stay, and higher healthcare costs. But nowadays, limited research findings related to the prevalence of falls in healthcare setting, especially in Malaysia, so requires early identification of this factor very beneficial in implementing intervention program to prevent falls in hospital setting. So this is the study objective. So to determine the associated factor of falls among older patients in HESAS. So this is the specific objective. So this is the conception framework. This is our independent variables, and then falls are our dependent variables. So methodology, so this is cross-sectional study. We do it at Hospital Sultan Abdul Aziz Shah, HESAS UPM. So we screen the patient according to this inclusion and also exclusion criteria. So sample size needed for this study is about 98%. Okay, so sampling design, we use purposive sampling and also convenience sampling. This is the study instrument. We use the self-developed questionnaire. We did the physical assessment. We go through the medical record and also patient bed head tickets and also face-to-face interview among subjects. So socio-demographic, we use the self-developed questionnaire. Okay, same goes to the medical background. We use the questionnaire and also medical record and bed head ticket, and also by interview. So anthropometry will assess BMI, and then we get the weight first and also height. Okay, and then we calculate the BMI using this classification of Wisden 2017. This classification is appropriate for older patient that age 60 and older. So for the dietary assessment, we measured the energy and protein intake adequacy. We assess the dietary intake using 24-hour direct recall of 2 non-consecutive days, and then we analyze using the Nutritionist Pro. Okay, after we get the intake, then we calculate the requirement using the Aspen guideline in geriatric, the energy requirement between 27 to 30 kilocalorie per body weight. Yeah. And then the protein requirement is around 1.0 to 1.2 for healthy older person. For acute chronic 1.2 to 1.5. For severe illness and injury and malnutrition, we set it at 2. So after we get the intake and also requirement, we assess the adequacy of intake using this formula. And then the intake of energy and protein more than 75%, we considered that as adequate, and the intake lesser than 75, we considered as inadequate intake. So risk of malnutrition, we use mini nutritional assessment, and then we classify the scoring according to this classification of malnourished, risk of malnutrition, and also well-nourished. So functional status, we assess functional status using the hand grip strength, using the JAMAR Plus digital hand grip dynamometer, and we use this cutoff point to classify uh, the ability of the muscle strength. Yeah. And then prevalence of falls, we assess history of falls for the past 6 months. We assess the reason of falls and any injury due to falls. We use this questionnaire, consists of yes or no question, and also open-ended and closed-ended questions. So this is the flow of data collection. We obtain the ethical approval from NMRR and also from HESAS. We obtain name lists from the system and screen patient based on the inclusion and exclusion criteria, and then all the eligible participants who are meeting the inclusion exclusion criteria, we invited them by providing information sheet and also written informed consent. And then the data collection started on February and also until April. Yeah, and then we appreciate all the respondents. After that, we did the data analysis using the SPSS version 27, and then statistical significant we set at P below than 0.05. All the categorical variable we use chi-square, and also continuous variable we assess using the logistic regression. So let's go for the results. Okay, from objective number 1 to determine socio-demographic, medical background, anthropometry measurement, dietary intake, risk of malnutrition, and also functional status. So socio-demographic, the mean age of the patient is about 69 years. Okay, with majority of them are male, Malay, married, and also living with family. Majority of them present with comorbidities and also having polypharmacies, okay, about 88%. So for anthropometry measurement, we shows that almost 38% having underweight, and also about 27% of them are overweight. Okay, risk of malnutrition, 58% at risk of malnutrition, and 27 actually already malnourished. For the hand grip strength, 78% of them high at risk of the muscle weakness. Okay, for the dietary assessment, so almost 70% of them having inadequate energy intake. Same goes to the protein. So 60% of them having inadequate of the protein intake, and sadly, this is the very sad finding, about 64% of them not referred to the dietitian. So prevalence of falls, about 35% of the subject uh, are having falls. Okay, so this is to answer objective number 3, association factor of falls. We use the chi-square. We found out that marital status, polypharmacy, dietitian referrals, and also nutritional status by MNA are the significant having a significant association with falls. Okay, there are no other variables shows the significant factors. Yeah. So discussion. So significant association were found between marital status, polypharmacy, referral of dietitian, and also at risk of malnutrition. Single or widow of older patient having higher falling risk. So this one in line with previous research with a single individual tend to have a fewer social connection and less assistance available. So referral to dietitian seem to have a positive impact on lowering risk of falls. So this one similar to the previous findings, as a dietitian manage malnutrition, provide personal personalized nutrition care, which educate nutrition essential for good muscle strength and also body balance. Use of the multiple medication polypharmacy lead to drug interaction, adverse effect, feeling dizziness, impact balance, and increased risk of the falls. So this finding consistent with the previous studies. So no association between comorbidity in current study. This one contradicted to the previous findings that shows diabetes mellitus would increase risk of falls due to hypo or hyperglycemia episodes. As a conclusion, proper nutrition and referrals to dietitians tends to have protective impact on falls among older patients. Marital status, number of medication taken have to be considered when assessing patient risk of falls during admission. So this study highlights the importance of dietitian roles in providing optimal nutrition care to the patient, including early nutrition screening, to identify patients who are at risk of malnutrition and early nutritional intervention to prevent incident of fall and also to ensure positive clinical outcome of the patient throughout hospital stay to prevent hospital readmission. So with that, this is the list of references that we use. Thank you very much. Thank you.